So I guess that we need to start because the main stuff to prepare for crisis is to rely on your forces and to be ready to do what you are doing, even though whatever happening around. And I will introduce myself. I'm Ganna Dovbakh from Eurasian Harm Reduction Association. I'm very happy to facilitate this amazing panel. And today we will speak about our ability, our skills on being mobilized to respond to crises, to be prepared for the crisis, and to be resilient. And with this resilience, we all hear it here and there, but for us to understand that it's not to be broken in the very hard moment, but be in the same shape, or be back to the same shape, or be back to the services, or be back to what we are doing, to the same values, to support people, even if the support will be different. Need will be different, world will be different, but we need to be resilient and supporting our people. So we will speak about harm reduction in conflict zones or in the war. And today we will hear from Lebanon, from the African Great Lakes region, from different parts of India, and also from Ukraine. And you don't have Tanya Deshko in agenda, and she's last breaker or late breaker, whatever. She came to respond a bit, to tell a bit about the harm reduction in Ukraine. And my question to all speakers was, what are the lessons learned from your situation? If you could have chance to have half a year before the crisis happened, what you would do? How will you prepare yourself? And honestly, we all know none of the government really take pandemic preparedness or crisis preparedness seriously. They are not investing in this. And specifically, they are not taking us as a civil society as a part of this process. If they prepare something, they are preparing for state processes, but rarely us. And in the moment of crisis, usually civil society is the one who left together with their people and need to support whatever tools we have. So that's what we will hear from our absolutely amazing panel, with the one clear question in mind: how to be prepared in our absolutely uncertain world. And what we see now, that this uncertainty, that's the new rule. The new norm. So for all of us, that's important lessons to understand. And we will start from Lebanon. We will start from Michel Wazan from the Schoon, Lebanon. Absolutely amazing activists in drug policy, and actually head of the drug policy program in Schoon in Lebanon. Michel?
Thank you so much, Anna. Can you hear me properly? I'm good here. Is that okay with everyone? So I think in one word, to answer your question, if I had a year and a half to prepare, I would spend that year and a half looking for a magic lamp, rubbing that lamp, and then wishing that the crisis never happened and that the war never happened. But great. So as Anna said, my name is Michel Wazan. I am the head of the drug policy program at Schoon, which is an NGO established in Lebanon since 2003. We're a harm reduction center and an outpatient treatment center for substance use disorders. Schoon provides inclusive treatment, education, and protection for people who use drugs across Lebanon. I don't know if you know about Lebanon, but this is Lebanon. So we're a tiny country on the shores of the Mediterranean. We're in the Middle East. We're surrounded by Syria to the north and the east, and by occupied Palestine to the south. So we're a tiny country of 6 million people. Of these 6 million people, 1.5 million are Syrian refugees, and 500,000 are Palestinian refugees. In this tiny country, we criminalize the use of drugs. So the Lebanese law on drugs punishes the use of drugs from 3 months to 3 years. At the same time, it provides the right to treatment as an alternative to prosecution, which it doesn't actually apply to everybody. But the fact that drug use is criminalized actually impacts people who use drugs in different aspects of their life, socially, economically, and of course, in their access to health services, specialized services. But what I'm going to be talking today about is I'm going to be talking about the work we've been doing to protect the right to life and health of people who use drugs in Lebanon. I'm going to talk to you about a campaign that started before the crisis and how it's been impacted by the crisis since 2019, because it's been, 6 years? We haven't gotten a break. I'm going to walk you also through the crisis, which might be a bit triggering. I've been crying through the making of this presentation, but I can do it. So in this little country of 6 million people, this is a bit to show you the scale of how many people get arrested per year. We've had years where over 3,500 people have been arrested, which is huge. And that's besides the people who get interrogated for using drugs. So they don't get arrested or detained, but they're still criminalized in a way. I'm talking about criminalization, and you've read that the name of my presentation has to do with overdose. Because when we criminalize the use of drugs, and I don't need to tell you that, all of you know it, we are putting people at risk of engaging in riskier behavior because of the fear of being arrested, like sharing injection equipment or snorting equipment. We're hiding substance use from healthcare providers and then not getting the care we need. And in the case of Lebanon, we refrain from seeking emergency medical care in cases of overdose and drug-related emergencies. So this is what we focused on since 2015. So in Lebanon, hospitals, because drug use is criminalized, have been calling the police on people who come presenting with an overdose at the ER. And so people would get either interrogated or arrested afterwards. And can you imagine waking up from an overdose and having to answer to the police? So what we saw is that most people would either not go to the ER or delay their going to the ER, which increases the risk of death. This was happening because of the confusion of healthcare providers due to a circular that was emitted by the internal security forces that said you have to report accidents that are committed by third parties. So like a car accident or a stabbing or a shooting or a beating. But if you've overdosed, chances are you've taken a dose that is bigger. So in 2015, we conducted a survey among people who use drugs. And we saw that, if you look at the graph, it says that 57% did not go to the ER the first time they overdosed because they were afraid of using drugs. Or, and the orange one is someone they know that didn't go to the ER because they were afraid of being arrested. So 32% explicitly said that it was because of they were afraid the police would be arrested. So we saw this as a huge issue, and we started advocating with the Ministry of Public Health, who issued a circular in 2016, which prohibited hospitals from reporting cases of overdose to the police. But what we found is that most hospitals did not really abide by this circular because they were still, there's a million reasons, including they were afraid of being prosecuted themselves for not reporting people who use drugs. So what we started doing is that we continued our advocacy with relevant ministries, the Ministry of Public Health, which is in charge of hospitals, but also the Ministry of Interior, which is in charge of the police, responding to these things. So we've advocated with both. We've had a series of circulars that were emitted prohibiting the reporting of cases to the police. What we've also done is worked with the hospitals, and we do a regular mapping of hospitals to ask them, do you report cases of overdose to the police? And do you know of the circulars? And if they don't know of the circulars, we send it to them so that they know that they are in the right to not report these cases. What we do with the survey is that we provide people who use drugs in Lebanon a map of safe hospitals they can go to in case of an overdose. So over the years, we've seen that most hospitals still don't abide by the circulars. Here are other circulars that were emitted in 2019. And you can see this is a safe hospital map we put out when we do the survey to allow people to seek emergency medical care in case of an emergency. So in 2018, we managed to map 29 safe hospitals. Safe hospitals are hospitals that don't report overdose cases to the police. 29 out of 133, that's nothing. In 2022, that number decreased to 27, and I'll explain one of the reasons why, which is the crisis. But we decided that we couldn't stop. We got creative in the way we engaged with hospitals, with stakeholders, with administrations, with syndicates, with other NGOs, with hospital administrators to have this number keep growing and growing. Whoa, whoa, whoa. So 2024, we reached 55 safe hospitals, which is great. But you'll see that it's not an incremental number. So if you look at the details of the hospitals, they tend to change. And I'll explain why again. So this is the last iteration of the map, 55 safe hospitals across Lebanon. If you know Lebanon, you'll see that the south is not at all included in this map, and I'll explain. I'm just showing you some of the key metrics from this ongoing campaign. Am I late? Do I still have time? No, okay. So just if you look at the total in 2022, and you'll see a small dip. That's because in 2019, the country began collapsing financially, economically, socially. This is the uprising that began. When we talk about the collapse since 2020, by 2020, we had reached an inflation rate of 85%. The Lebanese pound, our currency, had lost 90% of its value. And the World Bank identified the Lebanese economic crisis as one of the 3 most severe in the world since the mid-19th century. So it was hell. Of course, so we had, during that time, 2019, 2020, 2021, we went through severe shortages of water, electricity, fuel, food, other essential life savings and saving services and essentials, but also medication. And as part of this shortage of medication, we unfortunately went through a shortage of buprenorphine or OHE medication, which severely impacted people who use drugs. I'm bringing this up because it's linked to overdose. As you know, if you stop taking your medication, you're at risk of a relapse, potentially of an overdose. 2020, we had I think it was the 3rd biggest non-nuclear explosion in the world. So that was fun. It was huge. It destroyed a big part of the capital. So you have 218 dead, 7,000 injured, and 300,000 displaced. If you look at this map, you'll see that there are 4 hospitals within the blow range. I'm not sure how to call it. Yeah, the blast site. All 4 of them are safe hospitals. So you see that during this period where the numbers of safe hospitals dropped, hospitals had been impacted by the financial crisis. Some of them closed, some of them no longer had ERs, some of them got blown up. And during that period, we had a huge brain drain in the healthcare sector where 40% of skilled medical doctors and 30% of nurses had left the country, which means that the staff was new. And because the prohibition not to report to the prohibition to report to the police cases of overdoses were not integrated into the policies of hospitals, it meant that new staff had no idea. So this is one of the explanations for this decrease. And then finally, we get to the war, which started in 2023 and is still ongoing despite the ceasefire. So from October 7 to January 2025, October 7, 2023 to January 2025, Israel conducted over 17,000 airstrikes on Lebanon. So the map on this side is all of Lebanon. And if you see that it's concentrated, the airstrikes are across the country, but they're very much concentrated in the south. And this is why we could not map any hospitals in the south. Can you imagine me calling a hospital and being in the middle of saving the war injuries and the people with gushing wounds and like being amputated? Are you reporting cases of overdose to the police? So we did not reach these hospitals, and that's we don't even know if some of these hospitals are still here. So we're not really sure what the map is going to look like next year. So I'm wrapping up just to say that beyond the impact on hospitals, the different crises have affected people who use drugs with the shortage of opiate agonist treatment medication, with their displacement because of the war, like some of the dispensaries were in high danger zones. So what civil society has done, not just Kuhn, of course, and all of its partners, we work to bring OHE into the country and ensure continued access to a medication. We got naloxone and distributed it at community level, which doesn't really exist in Lebanon, and we've been advocating for continued access, whether that's a higher take-home doses of OHE or that's moving the dispensary to a safer area. Of course, that's tough because substance use is still criminalized, and the government doesn't want to give people who use drugs bigger doses of their medication. They'd rather put them at risk to come and get their medication every week from a high risk area. So there's a set of recommendations that I'm not going to go into, but these were developed last year when we held a side event at CNG in which Anna was a speaker, Elia Araj from Menara as well from the MENA region was a speaker, and we had speakers from the WHO, Belgium, and that's it. So these recommendations talk about how to properly address the needs of people who use drugs in conflict and humanitarian settings. So happy to share those later. Thank you.
We could take one or two very short clarifying questions, because I hope that we will go through the presentations and then I hope to hear from you, your experience and your thinking, because we could not name only 4 regions in the crisis. And that's why if there are no clarifying questions, then we are moving to the next presenter. And you are thinking what you need to contribute from your side in the discussion part. And we are moving now to the Republic Congo and African Great Lake region. And I'm giving a floor to member Aaron Clevis, who is dedicated harm reduction activist with over a decade of experience advancing harm reduction services for key populations. Yeah.
Yeah, thank you very much. And good afternoon, everyone. I'm, as she said, Mbembe Aaron Clevis, and I'm coming from Goma in the Eastern Democratic Republic of Congo. So I work for Repro Justice Congo, and I'm a human rights advisor. So before I go into this presentation, which is related to the harm reduction in the conflict zone, where we conducted an assessment to explore the intersecting barriers to harm reduction services, but with focus on LGBTQ people who use drugs, but who are at the same time displaced in this region. So to come back to the question you asked about what we should do if we knew 1 year before about this crisis, I would say that in our context, it would be challenging because we are living the crisis since last 3 decades. So we are getting familiar. Probably the new development is the siege of our town by the rebel groups in January this year. And probably it is again an opportunity to think about how we should be prepared, because the crisis affected almost everything. So I will not take much time to tell you about my organization. We are a feminist and human rights non-profit. And our work, we focus on gender justice as well as access to sexual and reproductive health and rights. This morning, I was discussing with some friends who wanted to know where I came from, but he was not aware of where DRC is located. So I think it's better that I also explain a bit about the location of DRC on the map of Africa. So we are located in Central Africa, and we are a second largest country on the continent. So DRC currently, when you hear from the news, they used to refer to the eastern part because it's a huge, vast country, but the conflict is located currently in the eastern part, which has been affected by the conflict since 3 decades now, which is fueled by internal and external factors, but as well as the competition over natural resources. Because my country has more than 6% of existing reserve of coltan, which is a strategic mineral to fabricate batteries that currently, with electrical cars, it's a very strategic mineral. So in this area of Eastern DRC, we currently have more than 120 armed groups operating in that region. So we have local groups, but we also have rebel groups like FDLR, which is a Rwandan group, but which is currently operating in DRC. So since January this year, we experienced a very challenging development with the M23 rebel groups taking the city of Goma and the city of Bukavu, which are located on the border with Rwanda. So this has really negatively impacted the health system, because I would say that in that period of January, the harm reduction services were stopped and HIV services were no longer a priority. Why? Because hospitals were overwhelmed by the wounded civilians and militaries. So in May 2024, my organization conducted an assessment to explore the challenges faced by LGBTQ people who inject drugs and who are internally displaced. So the study was carried out in the city of Goma. We focused in 2 districts, and we also conducted the assessment in 3 IDPs camps. We couldn't move far in Masisi and Ruchuru because at that time, these territories were under the control of the M23. So we decided to conduct the assessment in the camps, and especially because it was targeting really displaced community. And the The purpose of this assessment was to identify barriers that hinder this group from accessing harm reduction services and harm reduction services. So as you can see on the map, at that time where we conducted the assessment, the government had only the control of Goma, the city where I came from, and some part of the territory of Rutshuru. So the methodology, we did a desk review. And here I want to make it clear that our assessment was qualitative in its nature, because at that time we estimated that the government has put in place a size estimation report showing the size of MSM, transgender people, and people who inject drugs across the country. So our focus was really to see about these groups and see what are the main barriers that hinder them from accessing this harm reduction services. So here there is just a list of key findings. One of the issues was stigma and discrimination by healthcare providers. But for this group, I would say that it was a double stigma and discrimination. First, because they were LGBT. The second, because they were people who injected drugs. And this discrimination was also documented by, done by humanitarian actors. We had cases where people would not receive humanitarian assistance just because they are LGBT. And another very complicated issue was the issue of GBV. I think there is one of the UN experts who has qualified the East of Congo as a world capital of rape, because of a big number of rape we register in this region. But for the LGBTQ people, we have documented some cases where women who inject drugs are victims of gender-based violence as a punitive measure by armed groups and sometimes by security organs. So in DRC, again, we have punitive laws. On matter of sexual orientation, there is no law punishing LGBTQ. But we have another legislation of protecting good morals of Congolese, which is sometimes used to punish LGBTQ people because of their orientation. In relation to drug use, we also have a law which is not really enforced, because if you go in a prison like me, I provide the legal aid support. We don't have many cases where people are arrested because of drug use. But the police people and some population with authority, they abuse, they arrest people, but most of the time is for extortion, to take their belongings, to take their properties, and they use their power sometimes to request sexual favors from women who inject drugs. And I would say that we have a governance challenge with a territory which is not fully controlled by the government, and sometimes these officers, they use their power to abuse these women. There is also an issue of limited harm reduction services. This morning I was telling people that when I hear about what other countries are doing, I would say that we are complete, because what they provide is the services to fight HIV. But there is a little conversation on human rights of people who inject drugs. And I would say, for instance, we don't have methadone therapy in Congo. and we don't have access to naloxone, which would help to prevent overdose. What we do is just provide condoms, HIV testing, and PrEP. But I would say that since the rebel groups took the city of Goma, we are experiencing a challenge where people who used to adhere to this PrEP are requested to come back after 2 weeks because there is no stock. So there is also that aspect of challenge. Another issue is the limited access to legal aid services. For instance, we used to have in the city pro bono lawyers who support poor people to access justice. But most of these pro bono lawyers, they don't agree to support LGBTQ or people who inject drugs because simply it contradicts with their religion and cultural values. And I would say that in the city, we are like 4 lawyers who can support these groups, knowing their sexual orientation. Yes, thank you. So, despite this, of course, there is a progress by the government of DRC. In 2023, we have adopted a new national strategy against HIV, which has recognized MSM, transgender persons, and people who inject drugs as key populations, with a number of interventions to these groups. The country has also developed the size estimation, which shows the number of these people, their geographical location, and services to be provided to this group. So, in conclusion, I would say that these studies, we have come out with some of the recommendations. And at that time, one of the recommendations was to integrate harm reduction services in the humanitarian context. So the time we were discussing with decision makers to start implementing this, it is the time when the city was falling under control of the rebel group. So I would say that currently we have new authorities, and we don't know how to uplift the gains we registered with the government. But currently there is the conversations between the government and the rebel groups, and we hope that the situation may get better and allow us to pursue with the harm reduction services. Thank you very much.
Thank you very much for your work and for your dedication. And it's really hard to do in such environment, and we all hope, always hoping for the best, and that the conflict will finish and we will be back to the real, like, peaceful life. But you are right, there are plenty of due to all over. Yeah, we there are Asia to India, and I will ask Roshan. Sorry, but I will not mistake in this. From the Project Accelerate to tell what you are doing in India with key populations and how you respond to the crisis in Manipur.
Thank you. I'll start my presentation with a disclaimer, because the talk that I'm going to present today will be focused mainly on a state called Manipur, where I belong, and it's not necessarily generalized across all other Indian states. So this talk is mainly about a state called Manipur, which borders Myanmar with a porous border of around 350 kilometers. So as you know, there is an ongoing conflict going on in Myanmar and then as well as in my state. So it was taken as a, actually this was, this initiative or this small evidence generation program was a PEPFAR supported program which phased out unfortunately in in April 15. So currently I serve as the president for Indian Drug Users Forum, and this doesn't necessarily represents the work of Indian Drug Users Forum, and it's mainly to do with the work that was supported earlier by a PEFA supported program. So actually, if you have to look at the state where I belong, Manipur, it is engulfed by an armed conflict. So arms are everywhere, and there has been an ongoing geopolitics and a proxy war that has been going on in the state. So I won't go into the details of the conflict there, but how this has influenced the drug-using population, and also how it has influenced the service delivery and how it could impact. It was we could take it as an opportunity in Manipur as such, because as we all know, the modus operandi of how drugs are scored, how drugs are used, greatly influence how the risk occasion could be covered. So because of the conflict, a lot of vigilante groups, a lot of militants have initiated anti-drug campaigns, and this has provided us an opportunity to engage with young people who use drugs as well, so, especially among adolescents who use drugs. So this evidence generation program, which I would call it, through the pre-harm reduction services, was mainly to define a service package for adolescents who use drugs, because even when I look up at literatures trying to look at what could be the adolescent-friendly service package for harm reduction or adolescent-specific harm reduction service packages, I think there are not enough literatures that could support or that could guide adolescents who have not attained a majority or 18 years of age as well. So the intent was to engage the government officials at the state level and as well as at the national level, so as to define standard operating procedures on how we provide harm reduction services to children lesser than 18 years of age. And the conflict gave us an opportunity to engage with such population as well. So because of the ongoing conflict, the drug routes have changed dramatically. So if you have to look at the neighboring states, there are 7 northeastern states in India. So if you have to look at the drug routes, it was through Myanmar and going towards Manipur, through the Silk Route, and also towards the Mizoram state. But because of the ongoing conflict, the drug route has changed. And besides this work I've been doing as part of our drug users organization evidence generation, we've been looking at interviewing a lot of the drug peddlers and also the opium farmers as well. You won't believe, after the crackdown at Golden Triangle, Manipur become a place where opiums are grown widely. And also a lot of backyard labs have been coming up in Manipur. So when I interviewed some of the opium producers, they said to produce raw heroin from raw opium, it is like the recipe of cooking chicken, as simple as that. So a lot of backyard labs and increasing overdose reports has been this thing. So because of the decrease or the adulteration of heroin or the availability of cheap drugs, the overdose rates has also increased because of polydrug use as well, to prolong them. Because clinically, if you have to look at the half-life of heroin in books is 6 hours. But if you look at the current heroin, the effect lasts hardly 5 to 10 minutes. So the injecting frequency increases. So even among young people who use drugs, it becomes more vulnerable when so to prolong the effect of the heroin as well, they started mixing with benzodiazepines or other drugs. So it became very complicated for them. And even when we respond overdose, it is not only opioid based. So naloxone doesn't work alone, and it becomes complicated and it has to be hospitalized, and it becomes very. I've got a good data on overdose as well, but today I will limit to this only. So you won't believe a gram of heroin costs $3 to $5 in Manipur at the moment. So it is like earlier in Manipur, where we use when drugs are cheap as well, because we border Myanmar and it is near to the Golden Triangle, it used to cost around 2,000 to 3,000 rupees per gram. But currently, at the moment, there is a widely popular heroin, which we see here. It doesn't look naturally white, but it is kind of a mix of chili flakes and salt. So it looks like that, and it's very cheap, and it is very popular among young people. So it is widespread among young people lesser than 18 years of age, not necessarily confined to Manipur, but also all the northeastern states. So it is widely being used. So in some of the states, it is called sunflower, popularly known as sunflower, and it's available easily. In one of the studies that was conducted in a state called Mizoram, we found that the onset of drug use, the first choice or the first drug that was introduced was heroin. So it was almost 36% among the young people lesser than 18 years of age. So, and we know what it might be when someone is using drugs as their first drug without any knowledge of safe injecting practices or even relying to older drug users as well. So this is a situation where there has been an increasing trend of cheaply available heroin, very popular among young people who use drugs. So we are trying to establish an evidence to state that to establish a need for children lesser than 18 years of age for provisioning services like opioid substitution therapy, majorly buprenorphine and methadone in India, more on buprenorphine, lesser on methadone. Few centers are there, but we were trying to justify the need for opioid substitution therapy among children lesser than 18 years of age, and also to provision needle syringe and exchange for children lesser than 18 years of age, because the current guidelines doesn't allow children to be provided with or to be registered into an harm reduction program. So this was a humble attempt in a small town or a small city, trying to establish evidence to negotiate or provision services for adolescents in need of harm reduction services. So I came from a state where the government are very flexible, and this is one of the well-known graphs where harm reduction works. So in the early 90s is when there was a explosion of HIV among people who inject drugs in Manipur. It was as high as 76.9% among injecting the drug use. So according to a current surveillance report, it has reduced to 8.8%. And this was mainly because when the state-based policy was formed, harm reduction was endorsed in the year 1989 for the first time in India as well. So Manipur was one of the first states where harm reduction was adopted as a policy in those years, where the first case was detected in 1989. So significant progress has been made, but this was also one of the rationale where we used to engage with the government of Manipur and in India as well in trying to establish the need for saturating the coverage among young people as well. So the missing cases was justified using these slides. So if you have to look at the existing policy guidance and advocacy efforts based on what has been available and how we can go forward. So the first excerpt is from the clinical practice guideline of opioid substitution therapy in India. So it is based, and there is a specific section on adolescents. So on policy guidance, it allows for children of 15 years of age to access buprenorphine-based opioid substitution therapy in India. But one section says under the discretion of the medical officer, if the need is been established and has been using established dependence on heroin or opioid-based drugs for more than 2 years, and if there has been history of sharing needle and syringes, he can be put on OST as well. Though the guidelines suggest this and it's been clearly established at the implementation level or the practice by medical officers, it is yet to be now provided to the younger population lesser than 19 years of age, because in one of the exclusion criteria, it also says that if there is no two failed attempts of abstinence, they cannot be included into the OST program. So we're trying to establish now. So there has to be two failed abstinence attempts for that. So so we established a lot of evidence in terms of dependence on opioid-based drugs for more than 2 years, so as to challenge this policy document and need for provisioning specific OST program for adolescents. So the National Health Control Program that the Deputy Director General has issued a corrigendum to all the implementing partners and the state-based policy, state-based control societies at the state level to start demonstrating or generate evidence on the provisioning of services for adolescents lesser than 18 years of age to provide provision harm reduction services. But there is a clear policy guidance as well. So this was through the technical resource group of people who inject drugs in India that this could be kind of influence as well. Then Manipur has a state it's not a state is egg. Manipur has a HIV Act. So Chapter 9, Section 22 of the Act provisions over and above any existing law that all services that have been provided, provision for prevention of HIV should not be should not be suppressed. So this the curriculum was also issued in line with the Section 22 of the HIV Act, and this also clearly states that the HIV Act supports all the protected persons, including the people who use drugs, to provision harm reduction services, including needle syringe program, opioid substitution therapy, over and above any existing law, including the Narcotic and Psychotropic Substance Act, the draconian law that is there in the Indian law as well. So over and above that act, these provisions have been this thing. These are some of the key findings. One more minute. So this is about generating the evidence on the need for OST program among adolescents. So there are clear evidence that adolescents need OST program because they've been dependent on heroin and opioid-based drugs. Then if you have to look at the injecting practices, so it's is widely injected. So even more than 50% inject 3 times a day. So if you have to look at the current drugs that have been available, the effect lasts a little more than 5 minutes, so they will inject more and more. So if you, and the current knowledge about HIV is very less, so they rely on their old timers in terms of how, because even if you have to look at, I started using drugs at a very young age, so the most I shared needle and syringes was when I relied to older drug users, because when I was not able to inject on my own, I was injecting a pharmaceutical drug called Spasmo Proxibon when I was using. So all my veins got blocked when I was injecting that drug, and I had to inject in my femoral vein. So while injecting in a femoral vein, I don't know how to inject on my own, and I had to rely on my older drug users. And this is when I shared needle the most, because this was when they will inject my dose and they will prepare a little bit with water and give it to me. So this was when I realized. So when many of the young people who inject drugs currently, if you have to look at, especially in the 7 northeastern states of India, it's like they're very vulnerable to bloodborne diseases. And this was also one of the myth buster, because if you today I heard Matt's session as well on peer-to-peer and needle and syringe program as well. So these challenges all existing guidelines and also thoughts on the peer-led intervention as well. So because if you have to look at the current outreach model, especially in India, under the National AIDS Control Program, is founded on what is called as the hotspot-based service delivery. So if you have to look at the structural barriers or even inflicted by the conflict situation, the concept of hotspot is gone. So you can't find concentration of people who use drugs at a typical point of the time in any place. Even the modus operandi of scoring drugs has also changed. It is mainly through home deliveries or even signals like loud silencer bikes riding as a signal that they are coming to deliver drugs and stuff like that. So we need to adapt and generate institutionalized systems on generating evidence, such local evidence, so that we could adapt the outreach model. So one of the best finding was on how we could implement a virtual outreach model in terms of reaching out to them as well. So we have got enough evidence to support or to initiate a virtual intervention as well in Manipur. And one of the greatest achievement of this evidence is that this activity has been included into the annual action plan of the state AIDS control policies, and further we are trying to define standard operating procedures on how we engage adolescent-friendly harm reduction services lesser than 18 years of age, and also to define an outreach model. So in the presence of Mayor and all the experts here in this room, I would also suggest if there could be global guidance on what could be the services that is specific or friendly to adolescents who use drugs, and that would really help all the adolescents across the countries as well. So this will be also one of the key learnings. I believe I don't have time to go through all this at the moment. So one of the greatest value-added services was the acute withdrawal management, because when I think I'll take only one more minute just to share my personal experience as well, because the door that was open to me to harm reduction services was a home-based detox program. It was not, I wouldn't say detox as such is not a successful program, but this opened doors to all the services, because this was the main attraction and a value-added services to all the adolescents that we engaged, because when we don't know anything, withdrawal was the only thing that we feared the most. So when we say those could be addressed with few pills, that was the most attractive services, because I still remember one harm reduction program in the early 2000 when my mom took me to a harm reduction service center supported by Oxfam in those days, where they were providing Loven pills. Even those days, I don't even take those pills. I'll put it under my tongue, spit it out, crush it and inject it during my detox also. I didn't take it orally also. But still then, that opened a lot of doors to many of my friends who were working in harm reduction, and I could get access to nil incidence program. And this is also one of the main reasons why I survived till this, because when I was injecting, my injecting frequency was from 7 times per day to 10 times. I was like, I don't have a vein to, like, even to when I need a surgery, I don't have a vein to collect my blood samples. I think this is the only small vein that I can collect or inject this thing. So that was the situation, but still then, by God's grace, and also because of that detox program for 5 days, it was just 5 days program, it opened doors, and a lot of those friends who were working on harm reduction were introduced to me, and this is how I still survive till today. And this could save many lives of young people. So even though many would say that a home-based detox program is a flop program, I would say this opens a lot of doors to this thing. And we found it as one of the key activities to be initiated when we engage adolescents who use drugs as well. I got more to say, but I think that's for now. Thank you.
Thank you very much for personal experience and describing in very details what are the needs in the war conflict. And I guess that we need to add on that not only adolescents start using a lot of drugs in the war conflicts, but those who are protecting us, who are fighting in the war conflicts, they also could be exposed to the different substances, and those who are relatives and people under the bomb shelters and all of us exposed to the war could have the mental health conditions to start drugs. And when we are speaking about harm reduction, we need to take it into account that it's absolutely new people. It's not the people we imagine when we are speaking about people who use drugs. It could be people who are heroes, but they start using drugs to cope with the trauma, to cope with PTSD, and how we are dealing with them. The same with adolescents. Today we had rich discussion on the children and harm reduction, and that's actually the key point, that harm reduction need to be as a part of the programs for children, for adolescents, for those who could be that's the drug education, that's the drug prevention we need to save lives. Okay, that was like a bit of summarizing, but I will summarize better. And again, if you will have anything to add on this list of how we need to be prepared, think about it, and we will be back to you after going to Ukraine. And I'm giving a floor to Tetiana Deshko from Alliance for Public Health Ukraine. She's responsible for the regional programs, but now she will speak about the Ukrainian harm reduction and fight in the hard times.
Or maybe this one, yeah, now it's working. Yes, yes. Thank you very much, Anna, and a great pleasure to be part of the panel speaking about very challenging situations in our countries and in our lives. I come from Ukraine, and conflict is not absolutely new to us. The war started in Ukraine almost 10 years ago, but the full-scale invasion started a little bit more than 3 years ago. Alliance for Public Health works in Ukraine, in region of Eastern Europe and Central Asia. It operates in some global projects, and the theme of harm reduction is very important for us. It's one of the major themes that we've been working on both in Ukraine and also in other programs we involved into. Because people who use drugs, and specifically people who inject drugs, are a very big population in Ukraine. We have estimated over 300,000 people injecting drugs. Well, the preferred drugs of choice have been changing, but still most would be injecting opiates. Quite a few, and the trend is growing, will be using multiple types of substances, and stimulant use is on the rise now. And we are seeing this trend becoming stronger and stronger in Ukraine. HIV prevalence among people who inject drugs is at about 20%, and hepatitis C prevalence, it's a very high prevalence of over 60%. HIV infections were initially back in mid-90s occurring in the groups of people who use drugs predominantly, and that was the main drivers of the epidemics. But in the last year, just 20% of new infections are attributed to injecting drug use. Before the war, national budget of Ukraine was funding harm reduction programs almost fully. But when the war started, the Global Fund and PEPFAR became the main funders of interventions on HIV in Ukraine. As of January this year, programs are operating. Almost 60% of people who inject drugs are reached by prevention services. A growing number of people who inject drugs are receiving pre-exposure prophylaxis, and opioid agonist therapy is reaching to still a small population of Ukrainian drug users, but it's still one of the largest programs in the region. And then came 2022, February, when war started. As of now, it is a very tragical situation with 20% of our territory occupied by Russia. The population is shrinking down dramatically, back from 52 million at the rise of Ukrainian independence in 1991 to just 25 million people in the government-controlled territories. A major migration occurred when war started, with 6 million were displaced internally, and 8 million have moved to neighboring countries. Severe damage to healthcare facilities, 1 in 10 either destroyed or damaged, and a severe mental health issue for Ukrainians. On the picture that you see here, it's a picture that I have taken just several days ago. It's near my house, in Kiev, the capital of Ukraine, where a Russian ballistic missile hit a residential building, and under those rubbles there were 12 people buried. Well, these are the reality of Ukrainians. And just a little bit to the right, what you don't see is a house which had a long-standing secondary syringe exchange point by our Kiev organization, Club NA. That house was not destroyed, but all the windows and doors are gone. So indeed, this situation did bring a very substantial change to how we live our lives and how we operate. There were expectations that in such a situation of crisis, there would be a major outbreak of HIV, but it did not happen. So here you can see the annual numbers of new HIV infections registered officially in Ukraine, as well as registered HIV cases per 100,000 population. Clearly, because of people's displacement, we have fewer people registered every year, but even per 100,000, you can see that the line is going down. How this was possible? It was possible because of the still scaled harm reduction program operating in Ukraine. It very quickly transited from the national funding to the funding of donors, back funded by the Global Fund predominantly. You see that the reach was at the level of 190,000 before the war. It is kept at about the same number of people in the smaller kind of country and smaller population. So we can say that actually it's an increased effort, which is delivering needles, syringes, condoms, consultations, and HIV tests to the groups. It was also possible thanks to the sustained, that actually increased effort to operate opioid agonist therapy programs, which have actually increased significantly in the time of war. Here you can see how this quarterly increase was happening, and now we have the highest ever number of people on OAT. It's over 22,000 people. Who are provided with services in over 200 medical institutions. 90% of patients receive take-home dose, which has been so critically important in the time of conflict and turbulence, so that we don't make patients come to the hospital every day. And it was very, very patients as well as trying to reduce the burden on doctors. There are several medication options available in Ukraine. It's methadone, buprenorphine, and we even had long-acting depot buprenorphine, which was also a very important development in the time of war. And we are also using this experience to feed international programs and sharing experience with Egypt and Kyrgyzstan, who are starting long-acting depot buprenorphine within UNITAID project within Frontline AIDS Consortium. We also started operating mobile OAT home delivery, which are vans, which are operating in 6 regions of Ukraine and are delivering medication to the patients who are staying ill at home. But also, we are hoping to be able to actually develop this service further to make it into a proper take-home delivery of OAT, even for those who are not staying sick at home. HIV care cascade has been was also sustained in Ukraine, so you can see the comparison between 2017 until 2023. So it has also improved in many ways in case finding. Well, in ARV coverage and in viral suppression, this is something that has helped us control the epidemics. We had to make some of the very substantive changes to our services, developments in the services to be able to respond to the emerging challenges. And I will speak about some of them in the next slides. With the people's movement, as war started, we had millions of people fleeing Ukraine. We had to make sure that those who are on treatments, who are receiving HIV treatment, who are on opioid agonist therapy would continue their receiving the treatments wherever they are. We have established a database of service providers for ART, for OAT, across dozens of countries. And we launched a 24/7 hotline, chatbot services that were providing information for patients who were relocating to new locations. A patient may call and say, I'm now in this new town in Poland, where can I get my OAT? So actually serving as this very low threshold, very simple mechanism which helped to link patients to treatments in their new locations. So that was also, it was done online, it was done in hubs. It was groups of patients who were already organizing in some locations with most patients. They were starting to operate as peer social workers or case managers, helping to navigate every new case. For patients who so quickly had to flee their country's locations, they had to be able to find to establish contacts with their doctors in countries where they would not speak language very often. They would not understand the prescriptions. They would not be able to explain their needs. So we established an online counseling service by the doctors, infectionist doctors of Ukraine. 26 infectionist doctors were serving as online consultants to the patients who were moving. So in the 18 months after the war started, we have dealt with 40,000 appeals to this service for people who have moved to over 50 countries in the world. Thus, we were able to restore almost all of the patients who were initially lost in the first months of war. This led us to further digitalizing our work, and we have established we have started to lean more on telehealth services through online ordering, online delivery of commodities and of medications, as well as doctors' consultations. So our online platform provides doctors' consultations. These are infectious disease doctors, psychiatrists, STI doctors, psychologist consultations, paralegal consultations, social workers consultations, mailing of help boxes. You can go online to our website, Help24, and order the box of commodities you need with syringes, condoms, naloxone, drug tests, and HIV tests. And this has been assembled and sent throughout Ukraine. It is, as you see, these services are growing in their popularity, and we see that they are very, very relevant in the time of war. We started ARV medication deliveries just this year, and last year I have worked with 1,500 deliveries. Again, at war, you need to work 24/7. We need to have availability of advice wherever you are, whether you are on the move or in the bomb shelter or in any situation you appear. So we again made another step to digitalize our social workers. So we established a virtual social worker. It's an artificial intelligence-powered talking head, so to say. You can try on the QR yourselves, and you can effectively ask questions by voice or type them on HIV, harm reduction, hepatitis C, TB, mental health. We have populated this virtual outreach worker with information so that we have the control over the quality of information provided. And so he or she will respond to your question rapidly. So this is again something that helps the program deliver in various situations. Finding new HIV infections among people who inject drugs at war is a challenge, and it is so critical that we make sure that we link people early. So we've been working with a fleet of mobile ambulances. These are 17 mobile vans working in 14 regions who are doing HIV testing through the networks of newly identified HIV cases, and they through these risk networks we are able to identify higher yields of new HIV tests at the level of 4% in some regions and reaching up to 6% in the regions where key populations have relocated. So it's been a very important solution to be able to be mobile, responding to change, responding to the mobility of people within the country. Of course, when person is on the move, is in a new location, you cannot just say, I have only an HIV test for you when he is hungry or he has no home. So it was very important to add on humanitarian services to our work. And we were able to involve providers to deliver humanitarian services such as shelters and special shelters established for people who use drugs, for LGBT communities. We were able to procure some necessary home appliances for people to live in their new locations. We have provided mini grants for some basic support. Yes, here, this is a group of our harm reduction project, which has some power banks, which were so important with electricity attacks of Russia. New medications were also very important. I spoke about Buvidal a little bit, but we also started to work with long-acting cabotegravir as a prevention for men having sex with men in 2 cities of Ukraine. It was very important because these cities were receiving a higher demand, higher numbers of patients. So we started with 100 people, and now, well, possibly we could increase. We continued to work with young people. Working with young people in the time of crisis is critically important because these are the people who live in these circumstances and will have to rebuild their countries. So we did a lot of work for young people through our online platforms, through working in parties and festivals, through distribution of drug checking commodities. Maybe a couple of maybe 2 more things I would quickly mention. An important innovation we also started is related to working with people who use stimulants. It is a growing number of people among people who inject drugs who also have ADHD, attention deficit and hyperactivity disorder. Based on data, about 40% of people who use stimulants may have ADHD. So we tried to support them with medication which is registered in Ukraine, methylphenidate. And we are running a pilot now. We have reached 200 people altogether, and we have 55 people on the pilot now. And we have seen a substantial improvements in their both drug use as well as their behaviors, improved healthy environment, psychological health, physical health, and well, first and foremost, the decreased amphetamine use. And yes, maybe one last quick note on what has been done by our partners in Ukraine. There is a lot of well, trauma that military people are experiencing during war, and widespread PTSD, post-traumatic stress disorder. And we were looking for ways to support our communities, our men returning from the war with PTSD, and there is very important pilot on psychedelic assisted therapies, which are run now in Ukraine. It's a small project by Open Society Foundation. They initially were planning just to work with several dozens people. It got to 50 people or so. And they've seen very substantive improvements in depression and in PTSD for people who were going through these structured sessions. So it's actually a range of psychotherapeutical sessions, which are also combined with ketamine-assisted therapy, some of them. So again, something that, that occurred in a very challenging situation. More to go, and some improvements on legalization of medical cannabis as well. And some important lessons are that, yes, indeed, there are changes, there are new subpopulations and new risks emerging, people on the move, military, new drug scenes. We need to respond to that. There are new locations, people moving from one place to another. We need to be mobile, and digital assistance can really help in that. There are new medications which can really support us in these situations. Long-acting options must be looked into. MAT for stimulant users, again, ketamine-assisted therapy, what I have mentioned, and medical health, mental health has indeed has to occupy a bigger part in our harm reduction work. I would like to end my presentation with words of gratitude to many of you for your solidarity, for your support to Ukraine, for taking care of our request, both pragmatically but also personally. For helping us bring sometimes our things, our medications from places to other places. So yes, thank you very much for that.
In this case, we need to say Slava Ukraini, and response will be Heroyam Slava. That's usual stuff. Thank you, Tanya, and it's very hard to put in 15 minutes the work of more than 100 organizations and activists and peer-led counselors who were on the phone, sitting in the shelter and consulting and providing support, and still are. That's a point, that if you don't see Ukraine in news, it doesn't mean that we are not bombed. So that's like everyday reality. But coming to my question, we started with the question, if you had a year or year and a half or half a year, and you knew that something could happen, what you would be thinking of to prepare, to be prepared to the crisis? What you would do? And we had several answers from our panelists, but now I'm coming to you, and we have marvelous volunteer to bring the microphone to you. If you have something to share from your experience, from your thinking, from the session, maybe you are coming from other countries, experience different ways and coping and resilient. I have two speakers. We could start with you. You want to speak? Yeah. Please. Introduce yourself, please.
I am Clara Dawkins, and I come from Colombia. So I'm Colombian, but I work in New Zealand. I am truly humbled by all your experiences. I work in a country of 5 million people where we don't have LAIV yet, so long acting, and we don't have naloxone like intranasal, but we have a lot of Indian population, Ukraine refugees. I think what I say is education. It seems to be that the responses are very different according to the country. And one of the things that I struggle is that cultural understanding of substance use and how we can educate those who are not working in this field to understand that the trauma and all these things don't happen in isolation. So like in Lebanon, like I worked with refugees in New Zealand for a while, and it was really hard to see when I was talking about trauma and the potential for support and counseling, they almost didn't want to take it sometimes. It's like that was in the past. Drug use was very frowned upon. Women were not allowed to talk, which we know. So I think it's like the substance use and culture. And how can we prepare our cultures? Because if things continue as they are, we're going to have more trauma, more substance use, more availability. So my answer will be education. Thank you.
Thank you. Thank you. And we have speaker there and then Ellie. Yes, yes. Raise your hand, please. Yeah.
Thank you very much. The presentations were really amazing. My name is Ben Collins from Reshape in the UK. One comment, I would really be interested in seeing your work about ADHD and stimulant use, because it's really something that needs to be discussed more. But you mentioned an increase in stimulant use in the Ukraine. And also, Michelle, I don't know if you know the story, but Tetiana has talked about dramatic shifts in drug use during the emergency. And could both of you, I was just wondering if people were actually seeing substance shifts, which I was quite naive about. I figured if somebody was doing a drug, they would stay in their same lane. But Tetiana has talked about people stopping opioid use and going to stimulant use. And I think that's a very interesting element of the crisis.
Okay, maybe we will hear from Ali, from the gentleman in first row, and then we will come to the answering the question, and maybe panelists will need to add something because we're also the part of the discussion. Yes, Ali.
Yeah, thank you. Thank you for the panelists, very informative session. And to answer your question, I think, Ganna, the civil society organizations and the community organizations were always ready to support governmental efforts in the crisis situation. If I take the situation of Lebanon, for example, it was mentioned by Michelle that when we found that there is a stock out of OAT in few weeks, the civil society organizations in Lebanon and Menara, we managed to get donations and we handed it over to the government. The issue is that also Menara, during our work, we found that there is, in each country, they have somehow an emergency preparedness plan, but this doesn't include the key populations. So this is why, for example, Menara took the initiative and we developed the emergency preparedness plan in 6 countries. Then we supported the local organizations or civil society organizations to advocate in order to include this emergency preparedness plan dedicated to the key populations and people who use drugs into the national plan. Thank you.
Thank you. Maybe one more replica, yes. Oh, we have 2 more.
Thank you all for their presentation. They were really, really good. My name is David. I'm from Colombia. I work in the special jurisdiction of peace here in Colombia. And I work with fighters, state fighters and non-fighters. And usually you show that the states or non-state military, they punish, fight for the drug users. But in between the lines, when you spoke to the persons who are in the war, they use a lot of drugs. And their stories of drug use are in the war, in the development of the war, and after the war. as you say, and I want to ask you all if you have think or how do you can create a harm reduction strategies for the fighters in the war and after the war.
Yeah, thank you everyone for very, very good presentations. My name is Corfred Quell and I'm a medical researcher. We work with the Asian Harm Reduction Network in Myanmar. Unfortunately, our colleagues from Myanmar were unable to be here now, but I'm presenting on our work tomorrow among harm reduction efforts among sex workers in Myanmar. My questions are to perhaps the gentleman from Goma. There are similarities in the situation, and one of the things that we really saw was transport issues for people to, or in our case for women, to the harm reduction clinics. I just wondered if there was anything that came up in your work. And my other question was to the gentleman from Manipur regarding the use of amphetamine type substances and whether you see that, because that's very, very much something in we see in polydrug use in the Myanmar context. So thank you.
Super. So we have a couple of questions about drug use pattern changes. And about the other challenges in transportation and other challenges, but we also could conclude the session with your observations, maybe something you didn't manage to say during the presentation and now saying that it is the priority, what is the lessons learned. So I'm giving a couple of minutes to each of you, and we could start with Michelle.
Thanks everyone for the questions. So to answer just very briefly what you said, I think it's very important when you're targeting a population that is not from the country where you work to also include people from that community to be delivering these services. They are knowledgeable about the culture, the background, they are more likely to communicate more effectively with these communities. Just like we say in harm reduction, like the inclusion of people who use drugs as part of the response, nothing about us without us. To Ben, yeah, there was a shift. It depended on, for instance, during COVID, we saw an increase in the use of crystal meth because it was also being produced locally, whereas before it was being brought in from Turkey. So also it being produced locally impacted its price and it was more accessible. I just want to point that we, as SCOON and with the Ministry of Public Health, we took part in the conduct of the European Web Survey on Drugs in 2021, where there are questions that ask about the impact of the Beirut blast on your use and the impact of the economic crisis on your use. It's on the website, you can find it, you can find these results, and we have upcoming results in the coming months that ask about the impact of the airstrikes on your consumption. So if you're interested in that. To wrap up, I think I answered all of the questions, right? I would say it's important to have, at least for us, what we've learned so far is to have emergency guidelines that ensure that in times of crisis, no matter what that crisis looks like, people have continued access to essential medication, whether it's procurement of the medication itself or accessibility to the people. If I'm displaced, where do I get my medication? How do I make sure the stock is enough? How do I make sure there's enough money to get the medication and for me to buy it? So yeah, that's it for me.
Yeah, in terms of how do we ensure harm reduction services to the frontline workers or those armies who are fighting at the front lines, I think we need to bend rules. For example, if you have to take the example of India or Manipur as such, for example, when we talk about opioid OST, for example, opioid substitution therapy, one of the key medication for people who use drugs in times of war to address the withdrawal or to sustain when they are at the front line fighting for the fighting is to pursue we pursue a lot of corrigendums, for example, riders over and above the existing guideline, so as to provide take-home doses, for example. For example, if you have to look at the current guidelines allow only 3 days take-home dosing in India overall. So we need to bend a bit of rules. And beyond that, beyond the guidelines, we as drug users organization also do a lot of what do you call under the carpet stuffs, where we try to ensure those are done. But we can't be made public, but we ensure those are done, and these are very critical and one of the critical services that needs to be provided in times of crisis as well. And in terms of amphetamine type substances in Manipur, it is widely available and very cheaply available. For if you know, if you are from working in Myanmar, the place called Namphalong, which borders with India, at a place called More, where we used to do a cross-border intervention with Tetiana as well, long time back. Now those are like the red zones, and we can't even go there for almost 5 to 10 years. But still then, yaba would cost around 50 cents, half a dollar at that point. The chocolate flavored ones, those nice smelling. So, but it's widely available, even though we can't go to the borders of Myanmar at the moment, and it is almost impossible to go there because the militants from the other sides have occupied those front lines, and it's almost impossible to go there and also to get services delivered. We are in the process of finding some peoples within or neutral cases to saturate those places, but still then we are not able to go there. But still, I don't know, somehow the drugs are never tried. When we talk about heroin, anything, it's widely available and cheaper and widely available. And yaba is very popular among young people, even including young females. So very cheap and widely available. Thank you.
Yeah, thank you very much. To wrap up, I omitted to mention that we have a searing exchange program under the framework of Global Fund and PEPFAR. But in our assessment, a number of people who inject drugs complain about the size of the searing, which is harmful to them. They prefer to buy sometimes searing from pharmacies, which are expensive. And because of this, sometimes we see this behavior of exchanging searings. Another thing I would say is since the rebel groups taken the city of Goma, they have declared severe sanctions against people who use drugs. And we don't know the meaning or definition of severe sanctions, but when we interact with colleagues who use drugs, they mention that even death is included. And since the war, we have registered 11 deaths of people who use drugs, and no investigation so far was conducted to determine whether they were killed by the government army or the rebel group. About the work of our organization, I would say that we currently run a clinic called the Haki ya Afya in my local language, which means the right to health. And we also have a hotline, which was really critical in providing services during the war, alongside a WhatsApp group that we have putting together peer educators and the healthcare providers. So during the war, we experienced the cut of internet and electricity, and this internet group really, this WhatsApp group was very important in referring people. So to come back to the issue, to the question of supply chain, I would say really we are experiencing a very, very complicated situation. It's because I don't have a card. One, in Goma, the only way to get commodities from Kinshasa, which is far away from Goma, is the airport of Goma. And since the war, the airport of Goma is closed. They say that it was destroyed and no plane can land. So the only exit way we have is Rwanda. And as you know, Rwanda is very, very strict about drugs. So Currently, I would say that we are experiencing a stock out of commodities, and some commodities we can get is from WHO, but it is not really sufficient. I would say that since February, even in my organization, we don't have syringes. Thank you.
Thank you. Drug scene changed substantially during war for us due to some enhanced border controls and changed drug trafficking routes. Like there's no Russian heroin in Ukraine, or kind of much less than there could be earlier, but also due to movements of people within the country, and they would be arriving in a new place, which unexpectedly you would buy whatever is available there from a drug dealer. So some of the first observations we had an increase, like 6-time increase demand for naloxone, because various situations were happening then. And yes, the home, the production of simple like stimulants, salts, very popular in Ukraine, is also taking over because it's easier. You don't have to risk with all the transportation things. So indeed, this localization is also an issue, and also new groups occurring, effectively military people who war veterans or people in the combat because of trying to keep stamina, trying to also overcome pains during treatment or after mental health disorders. People start using substances, and I think globally it's like 10% of people who had war experience would have some substance use disorders. So Ukrainian army is 1 million army now, so we can be making projections in terms of how much still needs to be done. A cultural shift needs to occur with veteran organizations for whom harm reduction is very new. And for them, so it's a whole learning curve that would have to occur. Meanwhile, we as harm reduction workers would have to tailor our services differently to be able to respond to other needs of veterans, which are also mental health disorders, some other traumas. So it's broader than that. And we see some of the possible solutions for the people who are now fighting actively through some online interventions with psychiatrists also counseling online people who are with mental health issues on the front lines, as well as maybe delivering some of the commodities through online orders. And concluding, I would like to say that these are very hard times for us, that we should be making very important lessons that would make our programs better in the better days, because when the conflict is over, we will have massive health needs of various populations and very little resource. So we should really be able to do much more with much less, and we should be learning now.
I have several notes to conclude all the discussion. If somebody, if we could send the message to some very wise people or to some resourceful people, I would say, and actually that's us. The only wise and resourceful people who could deal with these problems, that's us. So to conclude, first of all, we need to build beforehand cultural understanding of drug use and harm reduction among different health workers. And that's important part because when the conflict is starting, then harm reduction becoming the community service, and we could not be underwater anymore. With our shelters, with our people, that's something where when we need integration with mental health care, with the primary health care, with the services for kids and adolescents, with the schools, with the local communities. So that's important part which is happening in every conflict. Then recognizing of harm reduction, especially peer-led programs, as part of essential health care, or essential and even essential crisis response. Because in the crisis, then in the COVID or in war, then Ministry of Health or local health workers calling social worker and saying, do something. And that's not how it should be, because this social worker, first of all, also have limitations. It's time limitations and mental capacity limitation to do something in the crisis. And this is important when we have state recognition of the service before the conflict, then it's easier to continue in the conflict. That was in presentations. Ensuring and planning access to essential health services and or opioid agonist treatment, IRT treatment as essential, and allow flexibility in providing medication for long-term or for flexibility without loan authorization, because with the electricity cut, you could not have online signature of layers of bureaucracy to allow people to get take-home opioid agonist treatment or start giving naloxone to people if it's not allowed before. And then comprehensive harm reduction services need include and plan housing, food, sexual reproductive health, addressing gender-based violence, which is in the conflicts and war is severe, overdose prevention, legal support. So HIV prevention is not enough. And that's just a very small portion of the harm reduction. And then cooperation with humanitarian organizations. We recognize that majority of our organizations had no even documents to receive humanitarian aid. It's God bless, in Ukraine there were two big organizations who have all audited done and all policies in place who could receive humanitarian aid to distribute to the key populations. But usually our organization not working with humanitarian aid organization, and humanitarian aid could know nothing about drug use, harm reduction, gender-based violence, so they could be absolutely ignorant, unfortunately. And then armed people, and that was already highlighted, and a lot of work after the conflict. So I hope that we will be strong together and supporting each other, and we will survive and cope, and we will be resilient to all the conflicts. Thank you.